بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم في the case of the week 7. This is a case referred to my center for an anomaly scan at 27 weeks gestational age. Here's a clip to show that the fetus is cephalic in presentation. Okay, second clip, at which you will notice that the aorta and the IVC are juxtaposed at their abdominal course, and both are to the right of the spine, and the aorta is to the right of the spine at the level of the fourth chamber view. Again, the same findings: juxtaposed aorta IVC with right-sided aorta to the right of the spine at fourth chamber view. On looking at the fourth chamber view, you will notice that there is a dominant ventricle from which two arteries arises, and both outflow tracts are parallel, with one dominant and one smaller. Actually, this is not a univentricular morphology, it is a biventricular morphology with a small hypoplastic left ventricle, diminutive, and atretic mitral valve. You can check the findings. And we said that this is the right ventricle because the septal leaflet of the tricuspid valve has septal attachment. So this is the morphological right ventricle, and it is seated to the right side. Another clip showing the mitral atresia, diminutive left ventricle, and the interventricular septum. And you will notice that the atrium has a common atrial morphology with complete atrial septal defect, and you will notice again in the following clips there is a small inlet VSD. Be apparent right here, yeah, with absence of the crux. Here is again the VSD, the common atrium, and you will notice normal pulmonary venous return to the left atrium and the right-sided aorta with mild pleural effusion. The tricuspid valve is incompetent with tricuspid regurgitation, and there is no absent inflow into the mitral valve. The clip here stresses on the double outlet of the right ventricle with two parallel outflow tracts. Another clip showing the same finding. And if you focus on this clip, you will notice that the smaller artery is partially committed to the ventricular septal defect right here. Again the same findings with the pulmonary smaller artery partially committed to the ventricular septal defect. And looking here, you will notice that apart from the outflow tracts, the atrial morphology is bilateral atria, right-sided atria, because the right atrial appendage is broad and pyramidal, like here in this case. Here is the parallel outflow tracts, and you will notice aliasing at the smaller artery, denoting increased flow velocity at this level. And you will notice that both of them are arising from the right ventricle and are parallel to each other. The smaller artery gives a branch at the level of the three-vessel trachea view. This is on the three-vessel view, denoting that it is a pulmonary artery. The pulmonary artery is smaller and is stenosed, reflected by aliasing of color. Here is a group of pictures to clarify the aforementioned findings. Regurgitation at the level of the tricuspid valve, normal pulmonary venous return, and the atretic mitral valve with the broad-based right atrial appendages denoting heterotaxy with right isomerism. The VSD and the common atrium. Tricuspid regurgitation. Aliasing of color at the origin at the level of the valve of pulmonary artery. The juxtaposed aorta and IVC to the right of the spine. Here is the normal aortic situs, should be to the left of the spine, like in this case and in this case. However, in our case, it is seen to the right of the spine, both at the abdominal view and at the fourth chamber view. And this is the morphology of atrial appendages. The atrial appendage, like in our case, is broad and pyramidal in shape, while the left atrial appendage is finger-like. So our case is right isomerism. Here is again the diminutive left ventricle, the VSD and the common atrium. The VSD again. The interventricular septum. And here you will notice the beginning of the outflow tracts. They are parallel to each other with a small pulmonary artery. Again, both are arising from the right ventricle, and both are parallel to each other. With narrow caliber of the, especially at the level of the pulmonary valve. You will notice here aliasing of color denoting increased flow velocity at the pulmonary artery, with a pulmonary velocity in excess of 320 centimeter per second, and a mild pleural effusion right here in this image. The common atrium with the two right atrial appendages, the atretic mitral valve and the VSD, and the aorta to the right of the spine. And here is an associated anomaly, which is left foot talibus clot left foot. So the findings in this case are juxtaposed aorta and IVC to the right of the spine with bilateral broad pyramidal atrial appendages denoting bilateral right atrial morphology reflecting heterotaxy with right isomerism. Levoposed heart with slightly increased levoperversion, double outlet right ventricle with aorta lateral and to the right of the pulmonary artery, pulmonary stenosis most accentuated at the level of pulmonary valve that shows aliasing of color and peak systolic velocity equals to 360 centimeters per second, unbalanced atrioventricular septal defect committed to the pulmonary artery with hypoplastic left ventricle and atretic mitral valve, common atrium and left clubfoot. The incidence of double outlet right ventricle is 3 to 6% of congenital heart disease in the fetus, 2% in postnatal life, and about 1 per 10,000 live births. Increase in diabetic pregnancies and risk of chromosomal anomalies is very high, 12 up to 45%, with a prevalence of trisomies 18 and 13, and to a lesser extent 22q11 microdeletion and trisomy 21. So microarray is recommended. Presence of isomerism, as in our case, virtually excludes chromosomal anomalies. Risk of non-chromosomal syndromes is low. Double outlet right ventricle comprise a group of complex cardiac anomalies at which great arteries entirely or predominantly arise from the morphologic right ventricle. They differ mainly in spatial relationship of great arteries and site of commonly associated VSD and the presence or absence of aortic or pulmonary stenosis. Ultrasound diagnosis at 4-chamber view, normal or with VSD at first and second trimester. The left ventricle become diminutive with advanced gestation, like in our case. Occasionally, mitral atresia is in our case atrioventricular septal defect, double inlet ventricle. 5-chamber view and 3-vessel trachea view. Both great arteries arise from the anterior ventricle and are parallel to each other. Lack of continuity of medial wall of aorta to ventricular system. So the ventricular septum, special relationship of great arteries, discrepancy in size of great vessels in case of atresia or stenosis, more common in pulmonary artery, and location and extent of the VSD. Associated cardiac malformations, pulmonary, most common in pulmonary stenosis, most common associated finding in 70% of cases. Mitral atresia, cleft anterior mitral leaflet, atrial septal defects, atrioventricular septal defect, subaortic stenosis, aortic coarctation, right aortic arch, persistent left superior vena cava, anomalous pulmonary venous return, left ventricular hypoplasia, double inlet single ventricle, right or left isomerism, complex corrected transposition of the great arteries, the right ventricle is left-sided. Associated extracardiac malformations, extracardiac anomalies are very common in fetuses with dwarf. They are non-specific for organ system, yet mainly CNS and GIT. Our case had left clubfoot. The differential diagnosis is transposition of the great arteries is the main differential diagnosis. Tetralogy of Fallot, common arterial trunk as in case of the dwarf with hypoplasia of one of the outflow tracts. The prognosis. The poor prognostic factors include tubular hypoplasia of the aortic arch, pulmonary atresia, hypoplastic left ventricle, single ventricle anatomy, mitral atresia, atrioventricular septal defect, heterotaxy. You will notice that all the poor prognostic factors that are in blue color are seen in our case. Right isomerism comprises group of findings such as agenesis of the corpus callosum, spina bifida, cleft palate, trilobed lungs, midline liver, duodenal and esophageal atresia, variable stomach position, absent spleen, gut malrotation, malposed inferior vena cava, two right atrial appendages, pyramidal shape, broad connection, univentricular AV connection, discordant VA connection, common anomalous pulmonary venous return, left superior vena cava, normal sinus rhythm, absence of fetal hydrus, and absence of intrauterine demise. Take home message: in my opinion, juxtapose the aorta and the IVC to one side of the spine, whether right or left is the most reliable sign for right isomerism in fetuses. Always remember, right is not always right. In case of parallel outflow tracts, think of transposition of great arteries or double outed right ventricle. VSD, pulmonary hypoplasia, diminutive left ventricle, and heterotaxy are common associations with dwarf. High risk for chromosomal anomalies. The risk for chromosomal anomalies is virtually absent in case of heterotaxy. Kind regards and see you soon. Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Amr Farouk.